40-year-old male patient presented with sinusitis and the swelling of the hand. Go on.
Okay, sir. Uh, okay, sir. Sir, I'm provided with an X-ray radiograph of an adult patient hand AP projection. Sir, I
Yes.
can appreciate there are multiple erosive changes identified along the
And
third digit. It's involving the proximal, middle, and distal phalanx with some of a
excellent.
trabecular reticulation, some lace-like pattern. And so there is
Brilliant.
also soft tissue swelling along the digit, which give a sausage shape sign. And
Okay.
there's no SH, bone density appears to be normal, and
Yes.
joint space also seems to be preserved.
Yes. What's your differential?
Yes, sir. Sir, my differential on this, yes, sir, sir. On the second hand, there's a reticular erosion which is subperiosteal, and
Yes.
also digit thickening. So my differential would be sarcoidosis
Excellent. What will you do
on
next?
this X-ray. Sir, I want to reconfirm the other manifestation of sarcoidosis and about the lung findings as well. And some, if yes, yes. Okay, sir, this is the chest X-ray frontal projection. I can appreciate there is an left hilar prominence as well as a prominent right paratracheal stripe, which seems to be there is a lymphadenopathy, which is hilar as
Excellent.
well as paratracheal location, and some reticulation in parahilar
What
region in
is
both mid
what is
zone.
the name of this sign, please?
So this is the Garland triad sign in which there is
Okay.
a lymphadenopathy in both parahilar as well as paratracheal region.
Okay. Excellent. See,
And
the patient
okay,
as the
sir, this
patient
is a
are yeah. This is the chest.
okay, sir. Uh, yes, sir. So this is the mediastinal window of a same patient lung axial images. And here you can appreciate there is an yes, sir, there is an lymphadenopathy with some calcification as well, which is in both hilar, paratracheal,
Yes. Yes.
and yes, yes. Yes, sir. Paratracheal, hilar, and as well as precarinal region. There's some calcification within the lymph nodes. The visualized section of abdominal appears to be unremarkable.
Okay. This is confirm your diagnosis. As the patient has a sinusitis complaint, we
Yes,
did
sir. Yes, sir.
this exam.
Okay, sir. Yes, sir. So there's a asymmetrical thickening also noted along the oropharynx. Okay, sir. So some mucosal thickening in which subtle erosion is identified in the nasal cavity with
Yes.
uh, um, both medial walls of maxillary sinus also seem to be eroded with mucosal
What
thickening, which is
what
enhancing
happened here?
mucosal thickening and perforation of the nasal septum as well.
Yes. Okay.
Yes. And
And
and some sir thickening also identified along the medial canthus.
radial
Yes, sir,
canthus.
medial
This is
canthus
the nose
of the
proper.
eye. And
No, this is the
yes,
nose.
sir,
See,
nose
see.
is
This is the nose
asymmetrical.
proper.
Yes, sir, with soft
Yes.
cartilaginous erosions and restriction as well.
So
The lacrimal
conclude
gland. So
conclude
this
what
is the
happened.
systemic sarcoidosis, which is seen involving the hands, skeletal as well as uh, mediastinal and sinuses of the patient. It is a multi-system
Excellent.
sarcoidosis.
Excellent.
And also, sir,
And
some thickening on the, yes, sir. Yes, sir, along the epiglottis and laryngeal supraglottic space, there is also asymmetrical soft tissue thickening identified.
thank you, doctor, so
Sir,
much. You did very well. You are John
thanks.
candidate or you are after John?
No, sir, October 22.
Brilliant. Brilliant. You did very well. See, doctors, from the beginning, she picked up the lace-like appearance and soft tissue thickening, so this is sarcoidosis. If you didn't suspect or put sarcoidosis in your mind or in differential diagnosis, the examiner will not give you the others: bilateral nearly symmetrical hilar lymphadenopathy and right paratracheal. If we are doing a nuclear scan, this is a 1 to 3 or lambda sign. And in X-ray, it has another name. Doctor, it is very difficult. Even me, I forget it. The doctor said it, Graldial sign, something like this. No problem. Okay.
Yes.
Then,
Oh,
then the chest X-ray confirmed, and
yes,
finally, it is
gastric.
a granulomatous disease, cause
Yes,
multisystemic affection in the form of nasal septum perforation
yes,
here. And see here, the nose proper or itself is thickened. Besides that,
yes,
there are epiglottic, okay, thickening.
yes.
Also,
Oh,
the cribriform plate is eroded, but really it is not obvious here because the images is so so small. No problem. It is a multisystemic sarcoidosis. One of the case scenario. It may face us in the exam. Thank you so much. Next candidate.
thank you.
Welcome. Next candidate. Hello.
Sir, I guess he is busy somewhere. Candidate 10, are you with us?
Next.
Yes, I'm candidate 10.
Who is ready? My colleagues.
Sir, candidate 10 is ready right now.
Okay, yalla, go. Female patient with a pelvic
Hello,
pain.
doctor.
Hello, doc.
Okay.
Female patient with a pelvic pain. This is only
So,
the single image, ultrasound image. Go on.
okay, so this is a transvaginal ultrasound
Trans.
showing well-defined hyperechoic rounded lesion uh,
Yes.
in the pelvis, measuring about 6 by 6.8 centimeters. It
Yes.
is homogeneous in ecotexture.
Yes.
There is no shadowing. Um, okay, so no evidence of calcification. Um, no other lesions identified. I'm trying to identify the adnexa and the uterus,
Give
but
me
they are
differential
not well
diagnosis.
seen.
See, this is a
Yeah,
limited study. Give me differential
yeah,
according to a limited study. Yes.
yes. First of all, I think about fibroid.
Is
Um,
fibroid
sec-
is fibroid hyper like this? What else?
usually it is hypoechoic,
What else? If I told you this
except
is
if there is
adnexia
hemorrhage.
lesion, if I told you this is
I
adnexia,
think about dermoid tumor
what will you do
containing
next?
fat, but it's usually
Okay,
more heterogeneous. I would confirm
okay.
it. I would ask for a CT scan or MRI, preferably MRI with contrast enhancement of the pelvis.
Leave the mouse, please.
Sorry.
This is CT. Yeah, go on.
Yeah, so this is a contrast CT of the abdomen and pelvis, multiplanar in the portovenous phase. I would
Yes.
scroll down toward the pelvis, the targeted region. I can It seems like I can't scroll down. Yeah, could you? Yeah, thank you, please. Thank you. Um, so the upper abdomen so far is unremarkable, including the liver, the kidneys, the pancreas, the retroperitoneum. So in the pelvis, again, seen a well-defined lesion within the vicinity of the right adnexa, uh, appearing of mostly lipid density. Um, it is well defined, no surrounding fluid. Okay, there is adjacent uh, f- lesion containing both fat and tooth-like calcification.
Yes.
Could be from the same lesion or could be two separate lesions.
What's your differential
My
diagnosis?
provisional diagnosis, would be dermoid tumor, maybe two dermoid tumors. The other side looks unremarkable, so it's unilateral. It appears uncomplicated, no evidence of ovarian torsion or ruptured dermoid, no evidence of aggressive features as well.
Give
So this
me
is
two
uh,
signs. Give me two signs of ovarian torsion.
yeah. On CT basis, I would look
Yes.
for yes, secondary signs mainly, like surrounding free fluid, twisting of
Okay.
the
What else?
mesentery,
What else?
surrounding fat stranding, the
Primary signs.
ovarian tissue. Yeah. The ovary would be located in the retrouterine region.
Excellent.
There will be hypoenhancement or non-enhancement of the compressed ovarian tissue and the lesion itself.
Thank you. What other complication could be of dermoid cyst?
Yeah, ruptured dermoid. That's what. That's why I
What
said
will
that
it
there are
cause?
no evidence of fat within the peritoneum.
Yes,
It will
excellent.
cause chemical peritonitis.
Thank you, doctor, so much. You did very
Yeah.
well.
So my interpretation. This is a non-complicated dermoid tumor within the right
Thank you so
ovary.
much. You did very well.
Most welcome, doctor.
My colleagues, this is another example of FIVA typical exam case. Very easy, very typical. You shouldn't face only miserable cases. More than 50, 60% are typical cases. And the examiner wanted to listen from you the basic of radiology only. And the remaining may be more difficult, more harder. But at least this is example of very typical, very easy case. Doctor, يعني I have to note, when you scroll from up, down, then you find the pathology here, then you start to talk about the abdomen. Why? Please, my colleagues, start to talk about the pathology first. Full description, full complete description, and management, everything. And if the examiner have time, and I didn't think so, tells him, okay, the abdomen is normal, including normal liver, normal like this. He know, and he knows that you saw all the normal organs. This is first point. Second, in cases easy like this, all of us talk too much. All of us do a lot of verbosity. Why? This is a typical simple case, and the examiner knows that, and he wants from all of us finish it within 1.5 minutes, 2 minutes maximum, including everything. So concentrate at the lesion, exclude complication, give a differential diagnosis and management. Thank you so much, like this. Okay. Thank you, doctor. You did very well.
Thank you,
But
Dr. Rami. Thank you.
welcome. But my colleagues, our task here to enhance your style, to train you more. Most of you are brilliant, but I'm trying to covering some defect that I faced in my examinations, your colleagues, many of people who pass FRCR. So we are trying to transfer our experience to you. Okay. Next one.
Assalamualaikum, sir.
Welcome. Salam. Female patient, 40-year-old, complaining of frequent discharge. Post, she have a recent CS section. Okay. Concentrate the history. I will repeat the history again. The patient complaining of frequent vaginal discharge, and she gave a history of 4 months ago cesarean section. Go on.
Yes, sir. Sir, can we have the control? I have.
You have the control.
So I've been presented with axial CT slices, non-contrast, in which I am scrolling all through. The upper abdomen appears grossly unremarkable. Bilateral mild prominence of the ureters, but that could be because of the back pressure from the overdistended bladder. Going down further, as there is a history of cesarean section and there is frequent discharge, so I am suspecting most probably vesicouterine fistula. I'm thinking in that line.
Okay.
However, I'm not able to delineate any fistulous communication, but I would like to see a sagittal view, if I can. Yes, sir. Here I can see, sir. Sir, maybe there is a small. Okay, I'm going in the wrong way. 1 minute. Yes, sir. Sir, I can see there is a linear defect in the anterior wall of the
Could you
uterus
indicate?
that is
Could you indicate
Sir,
by
here.
your mouse?
Sir,
Excellent.
this one. So there is a
Oh,
communication between the interior wall of the uterus that is communicating further with the defect in the wall of the bladder. And however, I would like to have a delayed scan in this CT, a delayed CT, relatively after 10 to 15 minutes. That will allow the bladder to fill and might allow the retrograde spillage of the contrast into the endometrium and then into the vagina, which will further confirm my finding in this case.
if I
Further,
told
I
you
can.
that the
Yes, sir.
patient has no time to wait, do you have any other clue to confirm your diagnosis, please?
Sir, the defect is very much clear.
Okay,
And
but the
yes,
the gynecological wanted more confirmation as a medical legality. Do you
sir,
have any
single
other
spot
clue?
from
What?
the same scan? From the same scan, sir?
You should do something
From the
else. Mm.
Yes, sir, I can do a single spot film of fluoroscopy to see
No,
the
by
fistulous
CT.
communication
By CT, what will
by
you do?
CT.
Mm.
Sir, I can retrospectively fill in the bladder with the help of a catheter and inject the contrast and see the communication and the passage between the uterus and the bladder
Thank
by
you so much,
clamping the
doctor.
uterus.
Thank you
Yes,
so
sir.
much. You did very well. All of my colleagues, could you see the defect? This one. Leave the mouse, please, doctor. This one. Okay. And see the urine. This is fluid. Okay. Intrauterine fluid from the bladder. You did very well when you told me I will wait for delayed. Thank you. And if the patient has no time, we can do ascending or cystography. The contrast will be retrograded from the bladder to through the fistula, then the intrauterine and down. Thank you so much, doctor. You did very well. This is one example of a subtle minor cases. Some examiner will not give you a history. Okay, he will tell you this is a pelvic pain, like this. Okay, subtle single abnormality. Thank you so much. Next candidate.
Thank you, sir.
Next candidate.
Candidate 12 ready. Assalamu alaikum.
Salam. Are you ready?
Yes.
12-year-old male patient with fever and cough.
This is a frontal projection of a chest radiograph of an adult male patient who's presenting with cough. The most obvious thing that I see is a bit of translucency over the left lung in comparison to the right side.
Don't worry about it. This is projectional.
Okay. Other than that, I don't see anything very, very striking. May I please ask for control? I haven't done that
Yes,
yet.
yeah. Ask,
Okay.
please.
Thank you. Yeah. So The mediastinum appears within normal limits. I see a bit of haziness and increased bronchiovascular markings along the right hilum.
Don't worry about it. See, doctor, this is projectional. The patient, maybe, but really he is centralized. So you
Okay.
feel here some haziness and here
Okay.
hyperurgency, but both of them are projectional. What else?
Okay, since I don't see anything obvious, I'm gonna go through my checklist. I see that the lung apices are normal. The superior mediastinum, the hyali are normal. The subdiaphragmatic regions are normal. I don't see anything very obvious in the retrocardiac region. The cardiac shadow is within normal limits. Nothing very obvious in the bony structures. I don't see any soft tissues are normal as well because I don't see any supraclavicular thickening.
Excellent. Look
Mm,
here. Look here.
okay.
What happened here?
Uh,
What happened here?
hmm. In the lateral projection, I see some densities projected over the left hilum. Other than that, I see a bit of diaphragmatic tenting anteriorly.
Both of them are normal. This is normal hilum.
Okay,
This is the
okay,
left, right copula, and what happened? Look at
okay.
the spine, please. Look at the spine.
The spine, I see one of the vertebral bodies. There's some lucency over one of the mid-thoracic vertebral body,
No,
one of them behind the
no,
hilar
no,
region.
no, no. Look
Um,
here. Look here. What happened here? When we go down, what should we see?
okay.
We,
We should see that the vertebral bodies are getting more prominent. What I see is a bit of lucency over the lowermost thoracic vertebral body, the
lucency or
costotransverse junction.
lucency or absence of normal lucency.
Yes, I don't see the shadow of the rib at its origin or joint with the vertebral body, the lowermost level. Um,
Doctor,
I would
when we go down, there
yes,
are more, not
soft tissues.
more, no, more gases. Normally, more
Yes.
gases. So
Okay.
here, the spine should be something more here. Should be here. What?
I'm sorry, I don't follow. I'm sorry.
Do you know the more black sign? Could you pick up the more black sign here?
The more we go down,
Yes,
the
it
more
must be
denser
more black. More
yeah,
black
the more
here.
lucency. Yes, yes,
Yes.
yes.
So here
But
we
but
loss of more black sign
okay,
again. Yeah.
okay.
It is very difficult case, by the way. See, don't worry. It's very difficult.
Okay,
Okay.
okay.
See, more
Mm.
loss of more black sign. Okay.
Like what you're trying to imply is that it's more bright, more opaque than it should be
Yeah.
on
Excellent.
this radiograph.
Excellent.
Okay, okay. So it's
Okay.
it's it's
So
more
we will
brighter
do
than
what?
okay.
Yeah. What will you do next?
We would like to proceed with a CT scan of the chest to look for any posterior mediastinal or spinal pathology. And while I see this contrast enhanced CT scan chest axial reconstructions at the level of the uh, liver, I
Look
see
here.
that there's a left paravertebral area
Yes.
of collapse consolidation, most probably the
Okay.
left lower lobe segments, showing air
Yes.
bronchograms. And I see that it's being directly, I want to see the aortic branches going through this area. I'd like to see. I see that this this collapsed segment of lung is being directly supplied by the branches of the aorta.
Excellent.
So this
What's your
could
special
be
diagnosis?
yes. So it's a pulmonary sequestration, most probably of an intralobar type, as it's an adult patient who's presented in his 20s. Had this been extralobar, the symptoms would have
Thank you,
been
doctor,
apparent
so
much
much.
more earlier.
Was very difficult. Yes, but take
Okay.
a home message.
Yes.
I will speaking personally for
Yes.
in 2 cases for me. It was something very subtle like this, and I have a doubt there are some increased density here in comparison to here at least, and I
Okay.
didn't want to tell the examiner. This is actually okay for me, and finally it was the key. If you
Okay.
could have a deep look here, it is very subtle increases density here. As
Mhm.
usually, I advise all of you, tell the examiner what is in your mind. Even wrong, okay. He will not demarcate
Right,
you.
sir.
Doctor, there are something here. I could see something abnormal increased density. Okay, you are right. Here, here, look, this is lower spine, looks like this is spine. So we lost of normal, more black side. So there are
Right.
some sort of consolidation, mass, even consolidation, almost consolidation. The CT confirm this consolidative mass with cystic changes applied from the aorta. So this is a sequestration. Okay, my colleagues, this is an arterial phase. We should also follow the venous phase to detect the venous return. If it is systemic or intracardiac directly through the pulmonary veins. Thank you so much. It was very difficult
Thank
case.
you. Thank you.
Welcome. Next candidate.
Candidate number 12, are you with us?
I'm 13.
Oh, sorry.
I'm
Okay.
No
Okay.
problem. 85-year-old male patient complaining of right upper quadrant pain. Request control.
Sir, I'm joining from my bed. It would be difficult.
Okay, I will stop.
Thank you so much, sir. This is axial non-contrast CT study of a triphasic renal CT scan. This is the plain study in which I can appreciate that bilateral renal margins are blurred. There is a large exophytic, apparently simple cyst arising from the periphery of the right kidney. In anterior relation to it, there is another cystic lesion which is showing some solid component as well. I would see there is also some soft tissue density seen within the gallbladder lumen. Gallbladder margins are also blurry. There are multiple degenerative and aortic calcifications seen. I would next like to see the arterially, the cortical phase of the same study. The kidney on the right side is enlarged. There is a cortical based lesion which is showing avid enhancement on this renal cortical phase, taking up arterial contrast, and there is central necrotic element as well. I'm like to see the the gallbladder internal soft tissue density is not enhancing. It could be sludge.
Don't worry about CC. Don't worry about the
okay, sir. Okay. So the larger lesion is cyst and the smaller lesion is a cortically based enhancing lesion. I would like to see the rest of the kidney poles as well, and would see it on the renal parenchymal phase to see the washout and its relation. On the renal parenchymal phase, which is I believe at 80 to 120 millisecond, this is becoming relatively iso to hypodense with the remaining parenchyma, so it's functionally not a normal tissue. And the renal arteries are not showing any filling defect. There are no surrounding. So my differential diagnosis is that it is likely a malignant exophytic renal cystic necrotic mass. And I would advise biopsy for correlation for this.
Doctor, are you sure this renal lesion, this markedly hyper enhanced lesion, should be biopsied? What is in your mind? Tell me what it could be in 85-year-old male patient.
Sir, it could be I would
What
like
is
to
the
take the
first?
history of
No history. What is the
any.
first differential diagnosis? Markedly hyper-enhancing lesion with central necrosis in very old patient in the kidney.
I suspect malignancy.
Yes,
Vascular,
yes, you are correct.
highly vascular malignancy.
Yeah, you are correct. What is the name of this malignancy? Some carcinoma originates from the kidney.
RCC.
Yes, very simple. Thank you. I bring this
RCC.
case specifically for this situation. Why? Even me, يعني, see, I also astonished when I faced the first easy case for me. I was in a big doubt. Is the examiner hide some disaster behind it? No, this is one of the 60 or 70% cases that should you face it. Very simple, very easy. Hypervascular lesion originates from the kidney with central necrosis, RCC, until proved otherwise. I bring this case because I'm waiting from the candidate to tell me to make a fatal mistake. Biopsy. RCC, not biopsy. Why? Fatal bleeding. Doctor, you did very well. You are so self-confident, but take care. Take care. Some examiner bring, especially RCC, to listen a fatal mistake from many candidates. Second point, we should rule out any renal vein or IVC infiltration. But this lesion is so small. Okay, my colleagues. By the way, this is a gallbladder. Almost this is stones. There are many types of stones inside the gallbladder. Many of them are calcified and many of them are not calcified. Cholesterol stones are not calcified. It may be cholesterol. Why not? Because it has a hypodense center. Maybe. Okay. Second point, it is overextended. It is surrounded by minimal smudging effect. It may be acute on top of chronic. Okay, no problem. If you tell the examiner like this, you will cover everything. Okay, my colleagues, thank you, doctor, so much. You did very well.
Sir, can I ask a question?
Yes.
Sir, what are we going to do next for this case?
Immediately, no biopsy. For RCC, they do either partial nephrectomy, total nephrectomy, whatever. Why? Because a biopsy will be fatal. But they will do first a staging CT of the chest. First, to rule out any hypervascular chest metastasis. This is the logic. Second, they will do transfer to oncology MDT to decide either what is first, chemo, radiotherapy, or surgery, whatever. But for us as a radiologist, no biopsy at all. Anyone have any other opinion? Feel free to discuss with us. Here we are a colleague. Originally, I'm your colleague. Anyone have any other opinion? Anyone have read anything rather than that? Even my colleague oncocytoma. Now, I will ask a very good question. Oncocytoma should also not be biopsy, and you should reject it. Why? Anyone knows? Who knows? Please write in the chat box. If anyone knows, please write in the chat. Why oncocytoma? What will our management? Yes, excellent, Dr. A. Thakur. Yes, iPhone, excellent. There are too many correct answers. Oncocytoma, excellent. Candidate 15 and 17, excellent. Excellent. All the answers are correct. Oncocytoma, you can differentiate oncocytoma from RCC, not by radiological means. I will surprise you even in pathology. I read in the Radiopedia many months before, maybe in pathology you can't differentiate RCC from oncocytoma, so they deal with oncocytoma like RCC in management until proof otherwise. They exceed the either partial nephrectomy, half of the kidney, total nephrectomy, what? Okay. Thank you, doctor, so much. You did very well.
Thank you,
This is a
sir.
common mistake. Don't we worry. See, my colleagues,
Thank you, sir.
again and again, the benefit and the role of this session to make all mistakes here. It is acceptable even one day before the exam. Okay? Why? Because there are a very good in radiology way to learn is a trial and error. Very effective. Second, following the next candidate.
Hi there, sir. Hi.
Hi. Hello.
Hello.
Are you ready?
Yes.
Take a deep breath for this case, please.
Requesting control.
Yes. This patient presented with headache, chronic headache, and sometimes he is a chronic patient, by the way. Sometimes he has a bilateral, unilateral, contralateral numbness. Okay, so his clinician asked us to do him MRA, and this flare sequence was acquisite. Go on.
Okay. So I'm presented with axial flare sequences of this patient. I'm trying
Can you
to scroll. I requested control, but I can't seem
Yes.
to control.
Yes, go on.
Okay. So I'm just looking through the images. It's not scrolling for some reason.
Okay.
Sorry, is it yourself controlling or am I controlling?
Both of us. I give you the control, but look here.
Yeah. So I can see small focal areas of hyperintensity seen predominantly in the white matter around the cortices. I can't see. I'm sorry, would you be able to scroll for me? For some reason, it's lagging. Hello? Hello, can you hear me? Sorry. Okay.
That's the control. Yeah, cool.
Okay, perfect. So I'm just looking through the images. Currently on these flare sequences, I can't see anything strikingly obvious. I'm just looking at my review areas. There seems to be slight bit of slight region of low signal.
What is this? What is this? What is the abnormality here?
The abnormality seen at the cortices is small focal areas of high signal between the gray-white matter junction. It's predominantly in the white matter.
So I told you that his clinician requests this MRA of cow, or MRA cow, and MRA neck. This is MRA cow. Okay.
Yeah. So I'm looking at the MRA. I'm just looking at the vessels. So I'm going to trace. Strikingly, I can see that the internal carotid on the
yes.
Yeah, on the is narrow caliber when compared to
right or left.
On the. So this is an MRA, isn't it? So it would be on the same side. So it would be on the right side.
Which ICA is narrow, right or left?
So MRA would be equivalent to what we're seeing. So it would be on the right side.
You mean this one or this one?
No, this one. Yeah.
Okay. What else?
Sorry, this would be the left side, wouldn't it?
Yes,
Yeah.
correct.
Yeah,
Correct.
left
Yeah.
side. So there's narrow caliber of the left ICA. I'm
Yes.
just looking at the vertebral arteries. They seem okay. Are there sequences? Just looking at the.
Take the mouse.
Can I
Take the mouse.
switch to the left, right?
Take the mouse. If I told you this is neck MRA,
Okay. So
would you
looking at
detect
the
any
vessel.
abnormality?
Yes, I can also see that there is narrow caliber of the entirety of the left common carotid from the
Huh?
origin,
And what
extending
else?
to. It's kind of got a beading appearance with focal area
Excellent.
structuring and narrowing.
What else?
Also, I'm concerned that there is a little focal stricture at the subclavian artery on the
Excellent.
left. I think there's narrowing in this segment here compared
Yes.
to, well, it seems quite large on
What happened
the.
here? Leave the mouse. What? What
Yeah.
happened here also?
Distally, there is loss of signal seen in the branches of the left subclavian artery.
Yes. And what
So
happened here also?
yeah, focal segment of narrowing is also seen with bit of aneurysmal dilatation. I believe this is on the right side. So the right brachiocephalic is quite large in caliber and then goes into the right subclavian artery, which is slightly
What's your
narrow.
differential diagnosis? What's your
With
differential?
the picture of large vessel vasculitis in a relatively
Excellent.
young person, I would say
Yes.
that primary differential would be Takayusi's arthritis. Other differentials include fibromuscular dysplasia. Now, in an elderly patient, I would think about atherosclerosis, and if it was small vessel, intracranial vessels that are involved, I would think about polyarthritis nodosa.
Thank you, doctor, so much. You did very well. This is the aim of today's session. See, if you remember my colleague in the beginning, most of the candidate was afraid from this major arthritis. But at the end, our colleague very easily pick up it. I know it is not easy to say a big rare diagnosis, but this is the diagnosis. The chiasoarthritis. The chiasoarthritis. See here, this is the normal, right? Main common carotid. No, this is markedly narrow and beaded appearance. Okay, multi-systemic, large arterial beaded appearance, including intracranial neck vessels and major aortic arch and major aortic arch arteries. So the chiaso, see here, the left subclavian distal part is nearly completely non-visualized. This is collaterals. See, this is the end. Really, honestly, this is the end. But see, this is collateral. So this is the chiaso until proof otherwise. Thank you so much, doctor. The case,
Just a
the
quick.
final. Yes, tell me.
You mentioned at the beginning on the axial flare sequences, there were a few areas of high signal foci. What
Yeah, it
were
may
they
be
related
ischemic change. Some ischemic changes related to the arthritis. Okay. But from the beginning, I told you the clinician ask for MRA. So don't take a long time in other things. Okay, doctor?
Thank you. Thank you, sir.
Welcome. The final case. Okay. One very important case, my colleagues. Who will be the last candidate?
Assalamualaikum, sir.
40-year-old male patient with headache and signs of intracranial pressure. Did you request the mouse? The control?
Yes, sir.
Go on.
Yes, sir, I requested. So I'm controlling this. Yes. I'm presenting with axial CT abdomen images and portal venous phase of a male complaining of increased intracranial pressure in the abdomen, and somehow it is not scrolling, sir. 1 minute, please. So can you scroll for me? Somehow it is not scrolling.
Okay.
I can see a simple renal cyst. I do not see any ascites in the abdomen. And the liver stain, the kidneys appear unremarkable.
1 second. My colleagues, all the attending session, try to answer this case. Very important case scenario. Try to answer, and I will ask after 2 minutes to type the answer in the chat box. Okay, after our 15 candidate 15 finish. Okay, go on.
Okay, I can see multiple cysts in the pancreas.
Excellent.
Throughout its parenchyma. However, I cannot see. I can see a simple renal cyst on the right kidney also. So multiple pancreatic cysts and renal cysts would trigger the suspicion of von Hippel-Lindau syndrome. So I would like to see the neuraxis of the patient, and since there is also there is a VP shunt in place here. Yes, and there doesn't seem to be any collection around the VP shunt, so there doesn't seem to be any intra-abdominal problem with the catheter. I would like to see the brain and cervical spine and the spine of this patient to see any cause of raised intracranial pressure. So can I see the MRI brain?
Before seeing an MRI brain,
there is no MRI brain, sir?
There are, but there are very important findings here. In von Hippel-Lindau patient, you pick up most of the findings, except the last one.
Yes, so can you please scroll? There can be multiple.
Concentrate in this slide.
This slice. Sir, I can see in the spinal canal some hyperdense area. Some hyperdense area in the spinal canal, which need to be further investigated if it's a spinal hemangioblastoma.
More than excellent. Really, really, you impressed me so much. We did this brain. We did this brain.
Okay. Then the axial flare images of the brain, which are showing hydrocephalus and periventricular CSFC page, and there is a hyperintense lesion involving the cerebellum with enhancing mural nodule and significant surrounding edema, which is compressing over the fourth ventricle and causing obstructive hydrocephalus. This is an urgent finding which need to be conveyed immediately to the referring physician so that the ventricular system can be decompressed immediately. Further, I would like to see down in the spinal canal to see any other associated hemangioblastomas. There is crowding in the foramen of magnum, and there is syrinx formation in the spine.
Sequence.
So can I see the sagittal? Sir, sagittal T1 with contrast. Can I see? On sagittal sequence, I can see that the fourth ventricle is almost completely obliterated, and there is tonsillar herniation and multiple enhancing masses within intramedullary masses within the spinal canal. And cervicomedullary junction with syrinx formation, which are suggestive of spinal hemangioblastomas and cerebellar hemangioblastoma in a patient with the von Hippel-Lindau syndrome. I would convey my findings to the referring physician for genetic and family screening, as well as MDT referral for this patient. And but for the first and the foremost step would be the urgent management of the obstructive hydrocephalus in this patient.
Doctor, thank you so much. You are more than brilliant. You pick up a very difficult, long case scenario. Even I help you in the beginning, but really it is very difficult. See, my colleagues, the key of this case here in the periphery, in this slide, VP shunt, ventriculoperitoneal junction, shunt, and hyper-enhancing intraspinal lesion. Plus this multiple innumerable pancreatic cyst and calcification, von Hippel-Lindau is the first differential diagnosis. Thank you so much. I didn't expect
Thank you,
that
sir.
anyone will pick up very easily like this, even by minor help. Thank you so much. Look, multiple
Thank you, sir.
hemangioblastoma. See my colleagues? Excellent, excellent, excellent. Really one of the most successful sessions that I made. I'm really impressed from all of you. Thank you, my colleague. Let's meet in the next Wednesday, 11, so not 11, 11
Sir, we have like
KSA.
four,
Yes.
sorry, sir. We have 4 candidates left. We'll adjust them on Wednesday then. Okay.
Yes, yes. Dr. Omer, please arrange with Dr. Akila and Dr. Miga, the coordinator of the group. And thank you, Dr. Omer, so much for today.
Oh, no
Let's
problem, sir.
meet.
Thanks to you sparing time on a holiday for us, and it was a brilliant session with the very good cases. Thank you so much.
You are welcome. Really, I'm so impressed and I am very happy from your attendance, from your performance from all of you. Welcome anytime. Let's meet in the next